all you.
Ready?
Mm-hmm.
Okay. Good morning. My name is Dick Davis, and my co-worker Neil Luttrell are giving a presentation on the passy muir valve. We started using these several years ago. This valve and speaking device has been around for several years. It was invented by David A. Muir, who was a graduate student. He was a trach patient, and he wanted to develop something that would allow patients to be able to talk with the trach after they recovered from the initial procedure of a tracheostomy. Some advantages of the passy muir valve is the voice speech production, improved swallowing, secretion management, oxygenation, restores positive airway pressure. We can use this device also on a ventilator patient. So with the device in place, the patient can talk, or voices will be produced. There's several types of passy muir valves. This poster illustrates several of them, different sizes. It does come in the pediatric version, which here at this hospital we've never used it on a ventilator or a pediatric patient, but it is available. The team players in this presentation and giving the patient ability to speak is, of course, the respiratory therapist. Speech therapy is involved, and nursing as well. Of course, we need a doctor's order for this speaking device. Usually in the ventilator-dependent patients, after we extubate the patient, usually there is an order for a speech evaluation. After they do that and make sure the patient is not having any problems eating and no aspiration problems or secretion problems, then we will go ahead with the placement of the speaking valve. With the initial speaking valve, you need to attach the speaking valve to the trach. It can be usually a Shiley, but you will need a fenestrated tracheostomy. So as the airflow passes the voice box, the instrument can be used. Here again, you would want to remove all the secretions orally and tracheally, so you have a nice procedure and evaluation. I might note that during the placement of the speaking valve is a little bit more involved when we are attached to a ventilator. You need to make sure that, here again, that it fits properly in line with the ventilator circuit, that you have a fenestrated cuff, or you decrease the volume in the cuff or deflate it so you have airflow through it. Now, you have to compensate the ventilator so the alarms won't be going off. You originally look at the pressures, peak airway pressures, and adjust the volume control to allow with the leak to be compensated for the leak. Patients have tolerated these procedures very well, and it gives them the ability to talk. There's some indications that you should make aware to the patient, especially when they go home. The valve can be left in place for humidity to be administered to the airway so the secretions will not be built up. They will be nice and thin. Now, if they are ordered and take breathing treatments at home, they recommend that you take the valve out while the aerosol treatment is being delivered. The medication has a tendency to block the one-way valve. So make sure that you instruct the patients on how to troubleshoot their unit, how to clean it. They have nice little tablets that they can order for cleaning of the unit, and it should be cleaned daily so you don't have any buildup of secretions or medicine or any other particular matter that might be through the airway. You always want to make sure that after you clean the valve that you let it dry and not put it back in wet. Some other recommendations in cleaning it: you don't want to use hot water. It will affect the one-way valve. You don't want to use bleach or vinegar, alcohol, brushes or swabs. Like I said, passy muir has a tablet that you can soak the one-way valve in. But we've had very good success with the passy muirs here and work very well with the speech therapist. Like I said, it's a little bit more involved when you have a patient on the ventilator, and we have in our policy and procedure manual the particular steps that you go through in making sure the airway is nice and clear and open, with suctioning, the adjustment of the ventilator, that we have enough flow, and especially the compensation that you need to make to the ventilator so you don't have alarms going off to adjust for the leak. We thank you for this opportunity to present this, we think, very important maneuver that we are involved in allowing patients. There's nothing more frustrating than patients that have trachs that cannot talk, and people, family members, appreciate it, and that now they can communicate with their loved ones. Thank you very much.